So I have a case today, and I said a stroke of luck because I believe in medicine, in neurology, we always need an element of luck if we want to reach to the final diagnosis. And this case just illustrates that fact. So this is the case of Mrs. ST, 70-year-old lady. She is hypertensive with no habits. She came with a sudden onset of confusion with inability to comprehend the language. It was of 24 hours duration, so outside the window period. It was possibly an acute stroke. Her pulse was normal, 84, regular. Blood pressure was marginally high. She was alert, aphasic with impaired comprehension, but she could mutter some sounds. She had right upper limb pronator drift, so probably localization was in the left middle cerebral artery, and no other abnormal findings. And this was her MRI. Is this Charlie? So if we see here, in the diffusion weighted MRI here, there is an infarct here. This one. It shows drop in the ADC. So it is and there is a small infarct here as well, in the right occipital lobe. So what we have is an acute infarct in the left MCA territory and in the right PCA territory. So left MCA infarct, right PCA infarct. And the angio if we see, there is no large vessel occlusion, but there was definite stenosis. But the stenosis was more in the right MCA territory, while the infarct was in the left MCA. And if we see, the vertebrobasilar circulation is mostly fine, except for the right vertebral artery is slightly stenosed. I hope this pointer is working. Okay. So this was the MR report. There was medium-sized acute infarct in the cortex and subcortical white matter of left temporoparietal lobe, that is left MCA, and small acute infarct in the cortex, subcortical white matter, right occipital, that is right PCA. But the focal narrowing irregular was in the right ICA, and there was focal significant stenosis in the left PCA, right vertebral, left PCA, and right ICA. So the infarcts were somewhere else, stenosis was somewhere else. So, and there was a chronic small vessel ischemic changes. So we did, ECG was normal, echo was just showing mild LVH, EF was normal, LS size was normal. The carotid vertebral arteries, the neck vessels were fine, and in an elderly stroke we usually do, so X-ray and USG abdomen were also normal. The hemogram, liver function, renal function, electrolytes, thyroid, sugar, cholesterol, everything normal. Mild CRP, ESR slightly raised, INR, triple H, D-dimer, everything was normal. So what we have is a infarct in two territories, and the atherosclerosis apparently was in the other territories. So what to do next? Holter was not done till then. So one is Holter. Anything else we can do? We eventually did the Holter. It was normal. I have not mentioned here, but it was not done then. So as neurologists, we always think what was the mechanism of stroke, and we thought that the ESR CRP was slightly high. So I thought she elderly stroke. So let us do for temporal arteritis. So the temporal artery Doppler was also normal. There was no evidence of the surrounding halo which is seen in temporal arteritis. Now, luckily, here is the stroke of luck. This was the complete report of the temporal artery. The parotid gland on both the sides shows small hypoechoic areas scattered in parenchyma, possibly involvement by connective tissue disease. Now, in a 70-year-old lady, I never thought of a connective tissue disease presenting for the first time. But this radiologist reported, he phone કર્યો કે સાહેબ આ પેરોટિડ આની જોગ્રન સિન્ડ્રોમમાં હોય ને એ વિશે તમે જોજો. એટલે then I did ANA, and ANA was +3 strong positive. And then we did the ENA profile. Row 52 was strong positive. The patient was aphasic. પછી I asked the son and daughter-in-law, dry eyes, dry mouth. They said કે પાણી બહુ પીવે, ખાવા બેસે ને એટલે દરેક કોળીએ પાણી પીવે. But she was aphasic. She could not speak any history. Dry eyes હશે, but then we referred her to the rheumatologist. So they said that she is primary Sjogren's syndrome. So eventually the diagnosis was stroke, left MC and right PCA infarcts. Now what was the mechanism? Was this vasculitis? What was it? Is just atherosclerosis, or what it was? Was it prothrombotic state related to Sjogren's syndrome? So now we did the EPLA as well. Now I don't know the significance. Apparently just the anti-beta 2 GP1 IgM was marginally positive. But they say that to prove it as EPLA, you have to repeat it. You need at 12 weeks. And she was already on heparin, so we did not do the lupus anticoagulant. Anti-cardiolipin IgM IgG was negative, and rheumatologists conveyed that this may not be of much significance. But still, what we did is this. We gave aspirin statin, she was already on. I gave apixaban. I thought I will repeat the EPLA after 12 weeks. If EPLA is positive, we cannot give DOAC. We have to give vitamin K antagonist. But I gave apixaban. HCQ as advised. Because the rheumatologist felt that whatever you say, this stroke may or may not be related to the primary Sjogren. It may just be incidental finding. My contention was that she is hypertensive. She has no diabetes, no dyslipidemia. She was thin and lean. And why should she have so much of atherosclerosis? And the atherosclerosis, the site was different, the stroke was different. So somehow it was not matching. So I gave her anticoagulation. But this is just 15 days back. We do not know now she is going to have recurrent stroke or what. So currently this is the treatment. Then I did some literature review. So what is this? So there is enough sporadic articles I could find. This was an article from Germany, that premature ischemic stroke in Sjogren's disease. And what they did was they did a study, very nice study. They took 3 cohorts. Sjogren's syndrome with stroke, Sjogren's syndrome without stroke, and stroke patients who do not have Sjogren's syndrome. They compared all of them, and what they found was that the incidence of vasculitis, Raynaud's phenomena, atherosclerosis, everything was more common in those who have both. So probably they concluded that premature ischemic stroke can happen in Sjogren's syndrome. This was one more case report from China. So we take with a tablespoon of salt, but recurrent cerebral infarctions in primary Sjogren's syndrome, the case report and literature review. And this was a 66-year-old woman, again with a left MCA stroke. And in past 3 months, she had developed cerebral infarction twice, even though she had no risk factors for atherosclerosis. And she was eventually diagnosed with primary Sjogren's syndrome based on history of dry eyes and dry mouth and positive SS antibody. Another article from Italy, cerebrovascular involvement in Sjogren's syndrome. And again, they said that overall there is a greater overall risk of cerebrovascular and cardiovascular accidents in primary Sjogren's syndrome patient. So what I went through all these articles, but what I concluded was that Sjogren's syndrome can cause vasculitis. EPLA can happen with Sjogren's syndrome, which is a prothrombotic state. And most importantly, what it leads to is endothelial dysfunction, and which itself can, in an elderly patient with some vascular risk factors, lead to premature atherosclerosis. So when you see atherosclerosis, which is disproportionate to the risk factors, so even because Sjogren's syndrome is probably a disease of the elderly. I think the median age of onset is around 50 or more. So at least you can do which was not my practice to do ANA in 70-year-old patients. But I think this patient did change my thinking in terms that when you cannot pinpoint some risk factor which is very specific, then you at least do an ANA to rule out that there may be some underlying connective tissue disease. And so this was my takeaway. So think of connective tissue disease like Sjogren's in patients with stroke of unknown mechanism, even if the patient is elderly. Specifically dig deeper in the stroke mechanism when conventional risk factors cannot explain the stroke. Primary Sjogren's can lead to vasculitis. If it is a CNS vasculitis, we will give aggressive immunosuppression, steroids and endoxan and all. If it is just premature atherosclerosis, we are treating with statins and antiplatelets. And if it is a prothrombotic state like EPLA, we are treating with vitamin K antagonists. So treatment needs to be tailored according to the mechanism which you think is plausible, and all of it can be plausible. So it's a gray area. But what I found eventually was that whatever skills you may have in medicine or in life, you need a stroke of luck.